Good afternoon, everybody. Welcome to my presentation this afternoon. All a bit strange virtually and digitally, so I'm assuming you can all hear me and see my slides. I'll give you a bit of an introduction about who I am and what I'm going to try and cover in the 15 minutes that I've got today with you, and hopefully you're enjoying the virtual conference so far. I'm Stephen Sutcliffe. I'm Director of Finance and Accounting at NHS Shared Business Services. I've been with SBS, as we're fondly known, for just over 5 years, but my history is NHS through and through. I joined the NHS as a graduate trainee a few years ago now, trained to be an accountant, was a director of finance in the NHS for a number of years, and a client of SBS. Very, very passionate about the NHS. I get up every morning for my mum, really. My mum's 83 now, going through the various treatments around the NHS, and I want to make sure she has the best experience possible. And my son, Charlie, has an acquired brain injury, so we're often contacted through the NHS, who has a personal health budget. So really passionate about the NHS. My brother's a liver surgeon as well, who loves to play around with real robots. I'll come on to finance robots soon. And I'm also passionate about NHS finance and transforming NHS finance. I want the finance function of the NHS to be world class, to be the best that it can, to ensure that the finance function supports the frontline services to deliver the best outcomes possible. Next slide, please. So for those that don't know who NHS Shared Business Services are, I'll give you a bit of an overview. We've been going now just over 20 years. The Department of Health 2000 thought it would be a sensible and idea for the NHS to act as an NHS and to consider one finance platform. We use the Oracle finance platform and to process many of its back office functions in that way. So the Department of Health created us as a pilot in the early 2000s, and in 2005 we became a joint venture with 50% owned by the Department of Health and 50% owned by Surrey, who are a technology company and bring a lot of capability for technology, which is obviously key to some of the presentation that I'll give today. We've got 4 lines of business: finance and accounting, which I'm responsible for, employment services. So about 500,000 employees are paid every month by SBS, procurement and IT. And absolutely, the passion is fabulous from our staff, and we absolutely are here to help the NHS save money, enhance quality, and release funds for frontline care. Next slide, please. So we started off as transactional, and many people use the transformational word nowadays, but that's absolutely where we're moving towards. We're moving on a foundation of success, of scale, of capability, but was also bounded in manual processes, was bounded in paper, was bounded in processing widgets, and we're very good at that. But now it's very much about how do we transform the finance function, transform the customer experience with that heart of saving money for the front line. Next slide, please. So hopefully you can read the details of the numbers, but just to give you some idea of my responsibility, we're a large shared service provider. We're one of the largest in the world. The NHS is obviously a large organisation. And what does that mean in terms of some of the things that we process? So we process about 7 million invoices a year. We've 225 billion pounds worth of NHS money moves around the system, which we're responsible for. We have about 500,000 calls into our call centre on a yearly basis, and 800 million pounds worth of VAT is recovered for the NHS on a regular, on a yearly basis. So hopefully that gives you some context of size and what we're about. And for me, therefore, automation and digital transformation has been what we've been doing for many years. We'll come on to the impact of COVID in a moment. But the post room is a great example for me. The 7 million invoices that we process, a number of those have always been still paper invoices, and we get the, please pay NHS Trust £10 on a scribbled piece of paper, literally some poor quality invoices. And we've transformed our post room from an automation perspective and a process re-engineering perspective. So we've got 15 people in our post room now. Back in 2005 when we started, if we're doing the scale of activities that we're doing now, we should have 130 people in that post room. So our redesign, our automation, our transformation goes right from the beginning of something landing into the organisation right through to delivering a service to our clients. Next slide, please. So we are extremely proud of the response and the support that we gave our amazing frontline services during COVID-19. And in terms of what we were faced with, as many organisations were faced with, we were faced with a reduced workforce, both in the UK, but particularly impacted by our India workforce as well. We had huge increases in demand and volumes from suppliers, from invoices, from the NHS needing to move things around really quickly, and we just happened to be going through a merger program at the same time, merging 74 CCGs into 18 CCGs for April the 1st, and April the 1st became an absolutely historic and unique day in our history and NHS history, because when we created those CCGs, we alongside NHS England and alongside our NHS provider clients made £21 billion worth of money was transferred across the NHS on April the 1st, which is an NHS record for the amount of cash that's being moved around. And that was obviously crucial to keep the NHS moving, to keep the NHS paying suppliers, to keep the NHS paying staff. We also repatriated our 900 UK office-based staff by the end of March 2020. In fact, I haven't been back into the office in 12 months. Obviously, a year yesterday was the announcement of lockdown, and we are now fully running all our processes remotely and as productively and efficiently as ever, and that's fundamentally been about the resilience and the automation and the technology that we've got in place. Lots of new starters as well, particularly in the early weeks of COVID-19. We had about 100,000 new starters coming through as GPs came back, nurses came back to help with the effort, and we made all those urgent salary payments. And of course, we had to keep the suppliers moving, the economy moving. We've got 250,000 suppliers, active suppliers that we pay for the NHS. In April and May, we paid £7.5 billion worth of purchase orders, 1 million supplier invoices, and not surprisingly, nobody was sending paper, nobody was in the office. We had to bring in technology very, very quickly to accept email invoices, and we therefore saw a 66% increase in the take-up of electronic invoices in those first few weeks. But ultimately, we provided that resilient service and enabled the NHS to do what the NHS was needed to do in such a difficult time for the service. Next slide, please. So I thought I'd just pick up on one aspect of automation. When people ask me to speak about digital transformation in the finance function, I can wax lyrical about many things, but they often want to talk to me about robotic process automation. As I say, my brother's a liver transplant surgeon at the University Hospital in Birmingham, and he plays around. He uses real robots in his laparoscopic procedures. Robotic process automation is technology that's absolutely right for improving efficiencies and improving processes within finance. The NHS is full of processes, and RPA is definitely applicable to many aspects of the NHS. We've partnered with UiPath, who are a vendor within RPA. I describe RPA, the vendors don't like this, as macros on steroids. They can run all day, 24/7. They can run accurately, and we mapped out 850 financial processes. We're very good at understanding our processes, and we mapped them all out, and we determined that about half of those were suitable for RPA. And as I say, it's not just about delivering things more efficiently. It's absolutely enabled our staff to be released, to be adding more value to the NHS. It's absolutely enabled us to improve our consistency and our quality. Robots don't make mistakes. They run 24/7. They run as you ask them to do. And it's a really exciting thing for me. And I'll just come on to the next slide, which will talk through some of the outcomes of the programme. Everybody wants to know how many robots we've got in place. We've got over 100 robots in place. We're in the top 2% globally of organisations and the implementation of RPA. That's not just public sector, that's all organisations. We're doing that across 250 financial processes. So all our clients, all of the CCGs are benefiting from the biggest robotic programme in the world. We're the only UiPath orchestrator solution in the NHS. That's the big robot that's controlling the small robots. And then some specific examples about reducing response times on chart of accounts, changing cost centres, doing reconciliations. Our first robot, and we've named all our robots, was Freddie, the foreign exchange robot. And previously it was a pain in the neck for that individual to go in and check the foreign exchange update. Oracle, that robot, as you can see from the slide, has significantly reduced the time. And overall, we've saved over 500,000 processing hours saved every year on the back of our robotic process implementation plan. And as I say, we've been at this for 3 years. It's just what we do. We're developing them all the time now. And I'm far more excited about some of the aspects of. I said there's 500,000 calls that are coming to the call centre every year. Some of the work, most of those are suppliers asking when are they going to get paid. So we're bringing in technology, not just chatbots, which are fairly basic in nature, but genuine automation and genuine AI into that space. We've got machine learning in our scanning capability as well that enables invoices to be identified and move through the scanning process really quickly. So the desire around particularly predictive analytics, artificial intelligence, machine learning is where I spend my time, and going deeper and deeper into automation, because finance has been the same for the 25 years that I've been an accountant. It's probably been the same since 1700 and something, when bookkeeping was first designed. But robotics, automation, just as it's changing our day-to-day lives, is absolutely revolutionising finance. And I want to be at the heart of that, and I want to help the NHS be world-class in this space. Next slide, please. Thank you very much for your time today. Hopefully I've given you a flavour of our drive around digital transformation for the finance function, our response to COVID-19, our passion and drive and excellence around robotic process automation, and then a future that we're looking for across all our corporate back office services. You'll have seen my Twitter handle at the beginning of this presentation. I'm also available on LinkedIn. Would love to get feedback and for people to reach out to continue this conversation. Enjoy the rest of your conference, and I hope to see you all in person when we're all back into some sort of normality. Thank you very much.
Hello everybody, and good afternoon. Hope you're enjoying the conference. And firstly, just to introduce myself, I'm Graham Mitchell. I've worked for the NHSBSA, worked for the NHS for 36 years now. My current role is Head of Provider Assurance within the NHS Business Services Authority. My role involves supporting primary care commissioners and providers delivering all of their responsibilities. There are several areas where we are generating improvements to processes for our customers through digitization, and I'm just going to talk about one of those today. My team has supported the increased use of electronic prescriptions, and in particular electronic repeat dispensing. So I'm going to share with you what we've done prior to and during COVID, and the benefits and the rich data that's been generated as a result. Next slide, please. Firstly, I just want to talk about the NHSBSA. Some of you may not be familiar with it. We are an arm's length body of the Department of Health and Social Care, and the NHSBSA was formed back in 2006, bringing in a number of different organisations together, and many services have been added to it since. But we provide a national service to help the NHS run as efficiently as possible, and we're part of the NHS delivering for the NHS. But every year, the NHS spends about £70 billion through our platforms and services that we provide. And you can imagine that generates a huge volume of rich data that we'll talk about a little bit later. Our purpose is to be the catalyst of better health. And I think it's fair to say for many years, our focus has been on silent running, being a reliable, cost-effective delivery of those national services. Now, what we're doing is we're going beyond that, adding value to the wider system in many different ways. We've got a fantastic digital development function. We've got data experts, as well as brilliant operations where we're adding that additional value. So just a little bit of a summary of the BSA, just so you've got that context. Next slide, please. One of the areas within the NHSBSA is NHS Prescription Services, who receive and process prescriptions to make payment to community pharmacies for the medicines that they dispense. And we share the outputs or the information from this to CCGs and prescribers to make their key decisions that they need to carry out. Until recently, that has been predominantly paper-based, and you can see from the image on the screen there that there's obviously challenges of receiving 11.5 boxes of prescriptions from 11,500 pharmacies from across the country every month. So you can imagine that's quite a time-consuming piece of work, managing 1 billion prescriptions a year, where we pay out £9 billion for the medicines that are being dispensed. So while we scan every single prescription and we use intelligent character recognition to read those prescriptions, there's still lots of paper handling and data entry that needs to be carried out. So we've, over recent years, we've transformed our prescription processing operation from being that paper-based for the majority. We've now moved to a digital solution. We've incorporated the flow of electronic messages and systematic validation to improve how our operation works. The electronic system, or EPS, is delivered and managed by NHS Digital, and that's been in place since 2006. And I think it's fair to say that the uptake has been relatively slow. And that's mainly because people are familiar with those paper-based processes, but those processes are not necessarily efficient. So more recently, we've worked with NHS Digital and local agencies, as well as GPs and pharmacies, to drive up the use and the effective use of EPS. And to do that, we've implemented a number of support mechanisms and a number of resources that we make available to each organisation at each stage of the journey through the process. Mainly thinking about what's the best way to support patients through that process. So we've included webinars to share best practice. We've got one-to-one support, patient-facing materials, and we've developed dashboards and monitoring tools too. And all of that's available through our website. If you just go to our website and search for EPS. So through this, you can see from the graph that that EPS, or electronic messages, now sits at 90% overall. And if you were present on the previous video, you would have seen that somebody mentioned 95%. Well, the 95% refers to if you just look at community pharmacy from a dispensing perspective. But overall, prescriptions are at 90%. And you'll see from the graph that the biggest increase has come when the pandemic started back last March. You see there that there's been an acknowledgement or a realization of the benefits that a digital solution can offer. So we've delivered the 90%, and it's delivered with what that's generated is a reduction in errors across the system. There's less need for human intervention. Mainly, we've also got a complete and accurate data set that we can then use for other purposes. So what we've, I suppose some of the benefits that we've generated is that in our own operation, we've delivered £10 million over the last 5 years of being able to reduce our operating costs. And more widely across the system, we've generated at least 85 million efficiency savings across the system. Next slide, please. So what did we do in response to the pandemic? I think you can see from the previous slide that the pandemic has emphasised the benefits of EPS, and I'm going to talk a little bit about ERD as well. And while EPS generates the benefits that I've mentioned, ERD also generates additional benefits that what we can see. So electronic repeat dispensing, or ERD, allows prescribers to issue up to 1 year's worth of prescriptions to suitable patients, instead of the normal EPS prescriptions. So somebody like myself who's on stable medication, I've got high cholesterol, and I have a atorvastatin every month. So instead of requesting this on a monthly basis, I have an annual review with my GP, who can then issue up to 12 prescriptions rather than 12 separate issues of those prescriptions. So real time saving for the practice. And some of the studies that have been carried out, it demonstrates that moving people to ERD saves just over 15 seconds of practice processing time. Now, 15 seconds might not seem a lot, but we'll talk a little bit later about how that adds up and generates real efficiencies for the GP practice. Using ERD as a GP contractual obligation, but it obviously has significant benefits when implemented well. Patients no longer need to go to the practice to get their repeat prescriptions, like myself, and that reduces the footfall into the GP practice. And during the pandemic, that's obviously supported the social distancing. It reduces the risk of people like myself running out of medicines, so they have a steady flow. Saves time for the GP practices, but as well as that, it also allows dispensers to manage their flow of patients coming in for the medicines that they need dispensed. So what did we do We had planned to initiate a pilot of ERD support to be able to achieve the benefits that I've talked about. And we collaborated with Wessex AHSN and the local CCGs to develop a support package for practices. And we took on board feedback from those involved on the ground, but also we took feedback from patients and patient groups as well. The pilot was due to commence on the 23rd of March with 3 GP practices. And you will remember that the 23rd of March is a significant date of when the first lockdown commenced. And I can't believe that yesterday was that anniversary. It's an incredible year that we've gone through. So on the evening of the 23rd, we were asked to roll out that support to every practice across the country. So by the Friday, so just in 4 days, we were providing a national service. And I can't emphasize enough that that was all possible through the willingness and commitment of many organizations and teams working together. But we did it. And the amount of great work, the new digital solutions and the collaborations that we've seen during the pandemic has just been incredible. And this is just one small element of that. So what did we achieve from the ERD work? Well, we've engaged with over 4,000 practices to date, sharing all of the different materials and this direct support, and all of that's available on our website. You can see there that the slide shows that we've increased ERD by just under 17 million, and that was to November. Well, I can say up to January, that figure has risen to 22 million, and mentions on the slide 73,000 GP practice time has been saved because of that. Well, up to January, we're now hitting 96,000 hours of GP practice time that can be reinvested into patient care, all down to us effectively implementing that digital solution. Next slide, please. So I've mentioned a little bit earlier about the rich data set that we've got. But so through the increasing the EPS and standardizing of prescriptions to include the patient NHS number has generated huge opportunities as far as what we can do with the prescribing data that we have. We've got the patient identifier, we've got the prescriber identifier, the dispenser, the medication, what and how much, when it's been provided, etc. We've got the experts to use those data, so we've got significant digital and data analysts. We've got data scientists, data visualization specialists, working alongside IG and information security, as well as subject matter experts to ensure that we manage and get the best out of all of those data that we have. So just thinking of ERD as one of the main challenges that GP practices have is to actually identify the suitable patients that can be moved on to ERD. It can be done with the systems that are available, but it's time consuming. So we've worked with specialists in the field to identify the criteria that can be used to identify those patients. And we're now able to share with every GP practice a list of patients who would be suitable for ERD using the prescribing data that we have. And that's been a game changer to allow GP practices to engage quickly with those patients and carry out the clinical reviews and introduce them to ERD. We've also produced dashboards, and I've mentioned about monitoring tools too. But in addition to the ERD, we've got several other areas where we've used the prescribing data to good effect. Another important area is polypharmacy. And we can now identify individuals who are on combination of medicines that could be deemed to be putting patients at risk, such as kidney problems, frailty, falling over, unsafe combination of medicines, and those patients that are on large volumes of medicines. So practices and CCGs using the data, as an example, have identified patients prescribing 2 or more medicines that are likely to cause kidney injury. And those number of patients have been reduced by 72,000 since the data became available. We know that patients on 10 or more medicines are 3 times more likely to be admitted to hospitals, and we can identify those patients really easily now. So that's just a few examples of the great work that we can do with the data. And it's all possible through the digitisation and standardising the data flows that we've carried out. Next slide, please. I just want to leave with a few final thoughts just for you to finish off with. I've shared just one example of how digitisation has driven improved processes and efficiencies, and there's many more. We have a better way of managing NHS prescriptions, and we've worked with local and national organisations to help prescribers and dispensers of those prescriptions to use these in the best way possible. So everyone involved in these processes needs to be engaged with that new technology and appreciate the benefits it can generate. So for example, just on the example, GP practices and pharmacies, understanding each other's roles and working together locally for the benefit of the patients. When that occurs, the patient experience around ERD is really, really good. So we've increased the efficiencies through the digitisation and enhancing more data for better decision making. And that's all been achieved through colleagues embracing the solutions and working together for the benefit of patients. The NHS long-term plan and recently published white paper is all about integration and collaboration. Digital solutions will play a key part and help facilitate all of that. We all need to have the mindset to break down barriers and work together for the benefit of local, regional, and national populations. Without this, we run the risk of not gaining the full benefit of the digital solutions being created. Thank you for listening, and if anybody wants to learn anything more about this topic or anything else that the BSA does, please do get in touch with me. Thank you very much. I hope.
Good afternoon, and thank you so much for giving me the opportunity to talk to you and share some thoughts and ideas around the opportunities and the challenges of moving to a more digital workforce model. Just by way of introduction, my name is Katherine Church. I'm the Chief Digital Officer for Surrey Heartlands. I am a genuine system role, so I am part funded by Surrey County Council and part funded by our health economy. And my role really is to work across our system, so across the boundaries of health and social care, looking for those scale opportunities where technology, joined up data, modern processes and platforms can bring us together to be able to deliver the most effective and joined up possible care we can to the residents and citizens of Surrey. And as I was thinking about this presentation, and thinking about workforce and the ability of our workforce to work in different ways, it's really important to note that I joined the NHS 13 months ago, and in fact I joined the public sector 13 months ago, so I come from a private sector background, and I had heard as I was coming into my new role that the NHS might be slightly slow to change, but I have only ever known health and social care in COVID. And what I have seen is a system that is able and willing to change and to move to a more digital workforce model. So what I'd like to spend the next 10 minutes or so doing is sharing some of the opportunities, I think, and some of the challenges of how we do that, and go into a little bit of depth on 4 of the things that we are doing in Surrey Heartlands to help us really drive towards that digital integrated workforce model. If we could move on a slide, please. I would like to cover briefly the impact of COVID on the workforce and some of those upcoming challenges. I'd like to have a bit of a critical think. I've been thinking a lot around what we have done very rapidly during COVID and actually how effective and safe has that been? And is this the right base for enduring digital transformation? And then, as I mentioned, go into some of our core digital programs, which I really think will support our workforce with the right tools and systems to be able to deliver care. Moving on, a slide. As we think about, and there is an awful lot of research statistics and information around the impact of COVID, the pandemic, on our workforce, the impact has been really clear. We have an incredibly high number of vacancies. We have staff who are tired and exhausted. And in fact, when you look at all of the surveys of leaders within the NHS, one of the key risks that they identify to being able to recover and get back to pre-pandemic levels of care delivery is workforce impact. But I think as I've gone and done the research for this talk, this is exacerbating enduring issues which the NHS has been suffering, so high levels of vacancies and high levels of digital capabilities in the NHS. So whilst the pandemic has made things worse, these are enduring issues, which I think in a way explains how the NHS was able to so rapidly change and move people back into the workforce. So as I sit on that sat and look across our system, what I saw was a rapid ability to change and to flex and to move things. So we saw thousands of people who were brought back into the workforce. So either people who'd recently retired, people from allied professionals coming back in. And that has meant the ability to change the way in which we think about recruitment, the way we think about validation of skills, and the way in which we deploy people across our organisations. So that flexibility, I think, is a really important basis for us when we think about how we organise and deploy our workforce going forward. So we've created some fungible roles or some ability to think about how and where we deploy skills to meet needs. And of course, needs were changing so rapidly during the pandemic. What we also did is we moved very, very rapidly to working in a much more digital way where it was possible to do so. So driven by an immediate need to relocate our workforce. So big swathes of our workforce relocated from working in general practice, for example, or vast areas of our hospitals and our mental health and community providers to work at home. And I can very honestly say that I have never bought so many laptops as I did in my first few months in Surrey Heartlands. So we had to move really, really rapidly, shifting the way and the places in which we work to new locations. We also adapted very rapidly things like virtual consultations. So where it wasn't possible and isn't possible to see people face to face, we were able to move very quickly to adopt brand new technologies or adopt technologies at scales in a way we hadn't done before. And now as we come out of this more enduring and critical phase of our work, we're really thinking more strategically about how we enable these episodes of cares to take place in the most suitable and most the best channel possible for practitioners and for patients. So at scale across Surrey, looking at remote monitoring. All of that requires an integrated digital infrastructure to be put in place if we're going to do this at scale and we're going to do it in a way that is sustainable. So that's the kind of background of existing issues and a system and a set of providers who are able to move rapidly with some changes in what we did brought upon by necessity. If we move on, I've been spending quite an amount of time and research and looking as we think about what our next steps are of what was the genuine impact of digital on our workforce. And we've just looked and spent a huge amount of work looking at virtual consultations. And in fact, we delivered around 400,000 virtual consultations between March and December, which was almost 50% of the total of our outpatients for secondary care. And that is bearing in mind there were a lot of outpatient clinics that just simply couldn't take place. But it is a very rapid take up of virtual consultations. And we saw something similar in primary care. As we've done more research and more insight work, what we found is that patients have liked the flexibility and have liked the convenience, but that has not been universally accepted and adopted. And as we've dug into and looking at the patients who have taken up these virtual consultations with us, then there is a real risk that by moving towards digital, we leave some of our patients behind, some of the most vulnerable people who don't have access to digital. We also found when we look at this that there is not an absolute adoption of virtual and video consultations amongst clinicians and practitioners, and there will be a number of reasons for that, which we are looking into, which I'd like to delve into a little bit more. But what we are finding across our systems is that the numbers of these virtual consultations, so we jumped very rapidly to adopt this new technology, that these numbers are tailing off across all areas. So that really does make me think about whether what we're doing is sustainable in the long term. One of the other things that we found is that the impact on clinical and administrative time is sometimes hard to quantify. Now, I'm not suggesting that we haven't had an impact and an ability to help clinicians and practitioners spend less time potentially per episode, meet a patient's point of need and their point of care at that immediate point, ensuring that they don't have to come back and see a clinician again. But the evidence is limited on that. And I think there are a number of things that we also need to look at to make sure that tools like digital and virtual consultations are really effective and useful for clinicians, is how we think about embedding these virtual consultation platforms into our electronic patient records. In secondary care in particular, if the virtual consultation sits outside of the patient record, if the clinician is not able to conduct all of the other things that they need to do, such as ordering prescriptions, if these virtual consultations are not easy to schedule as part of clinics, then they are going to be, I think, of limited impact going forward in enabling us to think about how we best make use of clinician time to address some of the backlog issues that we may have. So I think the need there is to think about how we intelligently design. Now we have a bit more time to go back and redesign those pathways. Where and how do we use digital? A couple of other things on there is around remote working as well. As I said, I've never bought so many laptops and we have never shifted people from one setting to another quite so rapidly. We all moved really fast, but is it safe and is it sustainable? So we're looking at the cost and the complexity of maintaining virtual environments and physical environments. We have a much more complex landscape of devices, so PCs and laptops. And of course, every time we open new ports into our systems, then we've got increased cybersecurity concerns. And now I think the opportunity is to really think and engage across providers and across the system to think about the right locations for the right types of work and the right types of digital tools to deliver. So what are we doing to address this? If we could move on a slide. So there are a number of programs which I'm absolutely delighted to be involved in to any extent at all, and really proud of the way in Surrey at which we're thinking about how we design our digital solutions and platforms to meet the needs of our workforce. And one of those that I'd like to highlight is our Surrey Safe Care programme. So this is a full-scale digital transformation programme by two of our acute hospitals working together in an extraordinarily close partnership of redesign of their model of care delivery, of a new model of engaging with their staff and designing the way in which their EPR is delivered. And what I particularly like about this programme is the way in which the teams have engaged with staff. So thinking about the digital literacy needs of the staff within the trust, and thinking about how the adoption of this new APR is going to be successful if people feel a sense of being brought into the programme, of having some agency over how the EPR is actually designed and delivered, and feel that the training in their own needs and their own skills is there. And there have been multiple sessions aligning and engaging with staff, which have been incredibly positive. And I think it's amazing to look at how the replacement of a system can be used as a scale digital transformation tool. Why that is also really important for us as a system is that there are aspects of the EPR which are going to be brought online. So taking paper processes, parts of the hospital processes or trust processes, bringing those as part of an integrated online modern architected system. So this is a real platform for us to be able to share data across primary care and secondary care, for example, of thinking about what the right platforms are to manage inpatient care versus care in the community. So a really important step as part of our integrated architecture. And of course, as we move to more modern platforms, we've got that open architecture, so that ability to flow data. And coming back to some of the points I made around how we integrate virtual consultations, remote monitoring technology, then having a modern EPR architecture gives us the place where we can embed this data so that we're sure that the data and the services that we are providing out are integrated back in so that the right clinicians and practitioners can access that data. If we could move on. Another thing again, so this very close collaboration between two of our acute providers has really helped the system think about how we share people, and resources across our system. And one of the things that we are starting to look at in Surrey Heartlands is actually what does a digital staff passport look like, and how do we think about how we share and passport skills and qualifications across providers. So it's something that's been happening in primary care. It's something that we're now looking at more widely within Surrey Heartlands. And again, having a small number of digital platforms and tools and modern tools is really helpful in terms of people's familiarity and the ability for a flexible staff pool, for example, to walk into a number of hospitals' acute sector settings and be able to pick up and work with the processes because they're familiar and they're trained in how those processes work. And if we could move on one, in terms of, again, thinking about how we at scale across the system enable and use digital platforms and tools to enable health and social care professionals to come together and work around the needs of patients. Another really important system program for us, digital program for us, is the Surrey Care Record. So this is our longitudinal care record. It's our local digital shared care record for health and social care professionals across Surrey Heartlands. And for me, it's another one of the jewels in the Surrey Heartlands crown of integrated health and social care. So again, selecting a small number of core digital products which are co-designed with our workforce, with our clinicians, with our practitioners, to enable people to come together, to share data, to flow data appropriately. So what we have in Surrey is that we have all of our acute trusts providing and sharing data into the Surrey Care Record. We have the vast majorities of our GPs flowing live data in. We also have data from our mental health and community providers. And by July of this year, we will have all of our providers working in a very joined up way across the boundaries of health and social care. This is really important when it comes to our county council colleagues. So thinking about our really complex residents with multidisciplinary needs, such as people with enduring mental health problems, such as people with frailty issues, such as isolated and lonely people. So having this shared care record really enables us to be able to come together and share that data. So if we move on one slide. Again, so the final part of the jigsaw for me here is, as a system, how we bring our digital infrastructure together and how we create a small number of commonly owned and commonly joined up and easy to access digital products and projects and platforms, which will enable our workforce to work with the best possible tools that we can possibly have and deploy for them. So important for me is the fact that we have a small number of patient administration systems and EPRs. So that gives us those really deep integration capabilities to flow data across the boundaries of health and social care. What this means is that any of our workforce are able to find the information that they need as easily as we possibly can, which takes out frustration, time wasted, the time needed to go and look up paper records or make multiple phone calls to actually find the data that you need to deliver that episode of health or care at the point when you are with that patient or planning for that patient. What some other work that we're doing is really looking at the architecture of how we bring these core platforms and systems together. And then once we've got that architecture right, how do we ensure that all of the digital products, the remote monitoring products, and things like virtual consultations, which are extremely useful digital tools in providing a more integrated end-to-end digital model of care, which is not good just for patients, but also for workforce efficiency. So how do we make sure that the architecture allows us to integrate those products and those technologies, again, making sure that the right data ends up in the right place to enable clinicians and practitioners to do the work they need to do. One of the other things for me, again, is moving away from clinical data and systems for a moment is, again, another thing that we have in common across Surrey Heartlands is Office 365 and M365. So we're all working on a very similar collaboration tool. And in fact, most of us have spent the vast majority of the last year working on Microsoft Teams as a collaboration platform. So one of the key things for me as we move towards a more integrated health and social care system is how can we leverage this asset that we have? So how can we enable people to work in multidisciplinary teams by doing really simple things like viewing each other's calendars, like being able to find email addresses, like being able to share documents amongst teams where that team is made up of health and social care individuals. So that's another piece of core work that we're doing, is looking at how we can look and use these common platforms to work across the boundaries of organisations and enable what could feel a quite tactical day-to-day ability to share, but really, really important when we think how frustrating it can be to work across the boundaries of organisations. And then a final piece for me is around our network. So having the right environment, having the right fibre in the ground and network so that we can flow these point of care solutions, so that we can enable the integration of our core applications and the ones that I've described in my talk up until now. How do we make sure that we do that in an environment that is integrated, that is via a network which can be accessed by the right people in a way which is absolutely safe and effective? So really thinking about how as we come together, how we are able to ensure that we have the right security and cybersecurity measures in place. So by way of quick summary of all of that, the opportunities that are provided to us through digital, I think, have never been more attractive. And I say that with my 12 months experience in the NHS. But I say that again, background of rapid change, of an absolutely willingness to work together across health and social care, across areas of health economy, such as primary, secondary care and community care. And by coalescing around a small number of integrated digital products, co-designed with clinicians, designed with the needs of the patient in mind, architected in a way that enables us to layer in new digital products. Those things combined together in an environment which is safe and secure, I think will really equip all of our workforce with the skills and the tools to be able to work in a very effective and joined up way. Thank you.